All right.
Everyone is in.
Okay. Uh, Good evening, everyone. I would like to welcome you on behalf of the Kansas City, Missouri Health Department to our panel discussion this evening as part of Eating Disorder Awareness Week. My name is Andrea Bough. I am Councilwoman for Kansas City 6th District at large. I am also the mother of a daughter who is in recovery for an eating disorder. My daughter was diagnosed the summer of 2011 at the age of 13. Joining me tonight is Dr. Denise Wilfley from the Scott Randolph University Professor of Psychiatry, Medicine, Pediatrics, and Psychology and Brain Sciences from Washington University School of Medicine. Also joining is Marie-Laure Firebaugh, a clinical research specialist, who is the program manager of the Body U program at Washington University Center for Healthy Weight and Wellness. And finally, Annie Seal, who is the chair of the Missouri Eating Disorder Council and is a parent of a person with an eating disorder. Welcome all of you tonight. Thank you for joining us on this very important and personal to some of us topic. I'm going to turn the discussion over first to Dr. Wilfley to speak to us a little bit about what eating disorders are, and then we will come back and give an opportunity for some question and answers, including those from the audience as well. And Dr. Wilfley.
Absolutely. So I have had a long-term passion for work in the area of eating disorders. It started in graduate school, and I've had the good fortune over the past, it's been close to a decade now that we have the Missouri Eating Disorders Council, and I am joined here by Annie Seal, who's the chair of the Eating Disorder Council, and I'm the vice chair. And one of the great things that happened in Missouri is that there was legislation passed to really support funding to increase awareness of eating disorders, both prevention and treatment and training approaches. So that's been really terrific. We had a lot of support to get this going, and wanted to acknowledge Rick's dream as well, because he was really critical to getting the council going. And Annie, I don't know if you want to say a little bit perhaps about the council while people have a chance to hear a little bit about it.
Sure, I'd be happy to, Denise. The council was founded in 2010, and we actually got to work in 2012, 2013. Our entire mission is really to sort of lead Missouri in both awareness and also improved access to treatment. So when we started this council, there was very, very little evidence-based sort of APA guidelines structured treatment available outside of St. Louis and Kansas City. And through the course of the last really 10 years, we have been really committed to not only training healthcare professionals throughout Missouri, but particularly in the community mental health centers on these evidence-based practices, how to diagnose eating disorders, how to put together an integrated care team, as well as this online program, which we're going to talk a little bit more about tonight. The presentation I can see is up now. So it's been a really exciting time for the council. I am really proud of Missouri and the work that the council does. We have about 20 people on it from around the state. We have treatment providers. We have experts, very nationally known experts in their field. And we work closely with Dr. Wilfley's team at Washington University in the execution of these programs. So anyway, it's been life-changing for Missouri. We actually lead the nation in these efforts. So it's really great.
Thank you, Annie. And so it's a very serious matter that we're talking about. I think one of the things that we wanted to do is to briefly highlight some key facts about eating disorders and to point out some resources that we have available. First off, it's important to know that eating disorders are not a choice, and that every hour at least one person dies as the direct result of an eating disorder. And that of all the psychiatric disorders, anorexia nervosa is the second highest. It has been overtaken more recently by opioids, but in general, anorexia is a very severe disorder that can lead to death. So it's very important to intervene. And eating disorders are the 12th leading cause of disability in young women in high income nations. Next slide, please. So when we talk about eating disorders, there are a number of eating disorders, but I'm going to highlight anorexia nervosa, which is really the disorder that there is extreme restriction associated with anorexia nervosa. With bulimia nervosa, individuals eat large amounts of food. They feel like they just can't stop once they get started. And they also purge, meaning they use extreme compensatory behaviors like diuretics or laxatives or vomiting or even exercise to eliminate the excess calories. Whereas binge eating disorder, it's a disorder of recurrent and persistent binge eating episodes, also associated with the same levels of disability as bulimia nervosa. And then there's the other specified or unspecified disorders. And let's think of those as having still a really significant eating disorders, but they may just have one or two of the features. There's purging disorder, individuals who have compensatory behaviors with no binge eating. But in general, if you think about the number of individuals in this lifetime that will have an eating disorder, it'll be 30 million Americans. Next slide. So who has an eating disorder? There's a lot of myths about who has an eating disorder. And what's most important to know is that eating disorders occur in individuals of all body sizes, all ages, genders, sexual orientations, and socioeconomic status. And sadly, one of the things that we know that in racial subgroups, people of color, they're half as likely to be diagnosed or to receive treatment. So we already have an issue with access to care, but there are subpopulations that even have poor access to care. So that is something we're very committed to as a council. And so eating disorders can actually occur in individuals as young as 5 and all across the lifespan. Next slide, please. The other thing I wanted to bring attention to is because eating disorders have been tended to thought of as someone from a higher socioeconomic status, it's important to know individuals of all income levels get eating disorders. And we also know now, this is a study we did showing that of individuals who reported eating disorders, a quarter of them actually have food insecurity. And it's more than double the US national average. And food insecurity is associated with binge eating, laxative abuse, dietary restriction, and clinical, subclinical bulimia nervosa. And we can certainly talk about what's behind that. But I do want to point it out that if you know an individual has food insecurity, it's very important to also assess for the presence of eating disorders. Next slide, please. So how do these behaviors become reinforcing? And just to highlight a few things, restriction actually can numb feelings, and then it becomes more likely that the individual can restrict, and it can numb out anxiety. There's also in our culture such an emphasis, particularly among certain subgroups, that overeating will lead to weight gain, and that fear of weight gain can lead to vomiting, laxatives, restriction. And some kids can go in and out of these behaviors, but others get really hooked and it becomes habitual. And then also negative affect, rejection can lead to overeating for stress release. Next slide. So what do we do about that? And I wanted to bring attention just to a couple of our programs for the Missouri Eating Disorders Council. We have the Body You program I'll talk about in a little bit more detail, but I wanted to point out to our eating disorder training, our 360 program. Next slide. So we've been blessed to be able to have the funding from the Missouri Eating Disorder Council to train professionals across the state of Missouri. We have digital platform to train individuals in interpersonal psychotherapy for eating disorders. We also have tape trainings of family-based treatment for anorexia nervosa by Jim Locke and many others. But just to sort of whet your appetite, these resources are for free. And one of the problems we have is we know what works for eating disorders. We know that we can treat eating disorders, but oftentimes we haven't put these evidence-based treatments into practice. And so that's one of the things that research to practice gap we've been addressing. Next slide, please. And here's an example of an upcoming webinar. And again, this is free, and it's focused on exposure therapy and the treatment of eating disorders. And there is a QR code there, and hopefully these slides might be available for you to have access, but I will give you, well, you can see at the end the contact for the webinar. Next slide, please. Body U, it's an online program that's free. It's been shown to improve body image and disordered eating. It's free for all adults in Missouri. And one of our Body U users, we pulled one. This was a lifesaver. It's helped me so much having a coach and all these resources. And so please check out our Body U program. I'll walk you through a little bit more. Next slide, please. So how do we do this? So how do we decide if someone should be in the Body U program? We have a screening that has been shown that people who screen positive, we can give them feedback that they are at risk for a probable eating disorder. And what we can do is provide them with a eating disorder program that is coached. If they are too severe, then we can refer them on to treatment. Next slide. And we have treated through this program, provided this program to 13,000 Missourians, and we've shown significant decreases in restrictive eating and binge eating, and we're in all the public universities, the four-year universities in Missouri. Next slide. We've actually been fortunate to be funded by the National Institutes of Health to evaluate these programs as well. And when we compared this to a referral to the counseling center, once individuals were, probable for eating disorders, and we did assessments, we found individuals that we gave our Body U program to had greater reductions in eating disorders, psychopathology, and that the more time they spent in the program, the greater decrease in binge eating and restrictive eating. And probably most important to us was that when we could give it to them right on their phone, they were 12 times more likely to receive treatment. So the importance of using these digital programs can't be understated, but so many of the programs out there don't have an evidence base. So we're very lucky that Missouri is funding to have access to this. Next slide, please. So more recently, we've been funded by the Office of Women's Health, given the high increase of eating disorders through COVID, to provide this program to teens. And Dr. Patty Cavazos at WashU and myself, along with other investigators, we've tested this program for teens based on our adult work, and we've shown that it is efficacious. And now we're taking it to schools in Missouri. Next slide, please. And we have been fortunate to secure statewide partnerships with the Missouri Department of Mental Health, the Missouri Coordinated School Health Coalition, the Missouri Association of School Nurses, and also the Missouri Child Psychiatry Access Project and the Missouri Behavioral Health Council. So it's really an important, as Annie said, this multi-sector partnership to solve these problems. Next slide, please. So what do we do? So once a youth is screened, they'll be sorted into low, high risk, subclinical, and also into probable anorexia nervosa. If someone is screened for anorexia nervosa, we will work with a nurse to provide referrals for immediate treatment. And then with the other risk rankings, we will give a tailored program for that. With the subclinical clinical eating disorders, there'll be a coach program that will also monitor their progress. If it seems like that they're not improving or there's any symptom exacerbation, we will make sure to get them to care. Next slide, please. So what does the program include? It includes meal planning and tracking tools, self-monitoring. There's also a lot of psychoeducational content, not only on how to improve weight and shape concerns, but also how to decrease social media use, how to combat loneliness, and how to deal with triggers of binge eating, and also the support of a coach that will be overseen by a licensed psychologist. Next slide, please. So schools can play a crucial role. Currently, in the past year, 627 cases of eating disorders were reported in Missouri public schools. And we know based on prevalence rates that the true number of eating disorders is actually 35 times higher. We know that eating disorders, for the most part, begin in adolescence or early adulthood. And we also know if left untreated, they can persist. So it's very important to intervene as soon as possible with eating disorders. And that's where screening is really important. Next slide. You can go back one if you don't mind. Can you go backwards to one slide? And if not, so basically what we will do, if you would like to participate in the Body U Teens program, just let us know and we can give you more information. Next slide. I also wanted to bring up, there is a TESA prevention chatbot that we found does decrease weight and shape concerns. It's free. It's available through the National Eating Disorder Association. So I wanted to provide that resource, and it's what we call a conversational agent. So it chats with you. And so that would be something that would be readily available to you as well. Next slide, please. And the slide right before this one basically just highlights the Missouri Eating Disorder Council as well as NEDA resources. And then I wanted to bring up also a phenomenal opportunity that's funded through the state of Missouri is the Missouri Disordered Eating Disorders ECHO. And what's great about these ECHOs that nurses or other community members, if you have a case that you want to present, you don't have to have any particular expertise, but you can get input from professionals. And that's all I have to say, but thank you so much, and really appreciate your focus tonight on eating disorders. I was going to turn it over to Annie, and she was going to talk a little bit about her experience of helping her daughter recover from an eating disorder, and then Marie-Laure was going to talk about her own experience of recovering from an eating disorder.
Great. Thank you, Denise. Do we want to first open it up for questions about the presentation before we sort of get into some other pieces?
I think we're going to go ahead and go with the presentations, and we'll come back with questions at the end.
Okay. All right. Mine's just a talking presentation. So, I just wanted to, first of all, I just want to say Denise did a great job on presenting that. And I just want to reinforce that Body U program is available now to all Missourians who are 18 and older. So if you have a client who's struggling or maybe can't access treatment consistently right now, this is a fantastic program to recommend. Because it is evidence-based and proven. And in fact, in 2010, the early iteration of this program was cited as one of the top 10 prevention programs for mental health in the country. So this is a program that Dr. Wilfley and some of her colleagues developed. It has gone through 4 or 5 iterations. The council has been very fortunate in that we have the latest and greatest iteration always. And I just can't reinforce enough to please, use this program for clients if they're struggling. And then in another year, once we have the teen program piloted and launched, we'll probably try to make that available to even younger people on a statewide basis. So I just wanted to put that plug in there because it's such a fantastic program. So so for me, similar to Andrea, my daughter had an eating disorder. She was diagnosed when she was actually presenting symptoms of an eating disorder, like seriously disordered eating at 12 and 13, but she didn't get fully diagnosed until she was 15. And that was when she had a very serious eating disorder. And I will tell you, as a parent at the time, I didn't know what was wrong with her. It is a very confusing illness for parents. There is a lot of deception and a lot of secrecy. And, it wasn't, it was hard for me to figure out exactly what was going on with her. Every night for dinner, she would tell me she had already eaten with friends after school and she just wasn't hungry and she had to study, sort of like reasonable excuses for skipping meals, but she was actually kind of, not flat out lying about the fact that she'd been eating with friends. She hadn't been. It wasn't until, it really wasn't until a teacher called from her school and said, asked me what was wrong with my daughter. She had, her grades had suddenly just started sliding downward, and she had noticed a big change in my daughter's behavior. She was going through a lot of moodiness at school. This teacher could tell my daughter was isolating more and more. And she called me and she said, "Have you considered that your daughter might have an eating disorder?" And I had sort of considered it, but I really didn't know much about this illness. I just thought, it was odd that she wasn't eating, but I didn't put the rest of the pieces together. And this teacher really helped the pieces fall into place and helped us really get into action around getting her correctly diagnosed and into treatment. And I just stress that because the school program, this intervention program we're talking about putting into schools, I think is so, so important for driving earlier diagnosis and intervention, and even heading off the disordered eating behaviors. This is a highly effective program for that as well. So that's why it's a top prevention program. I wish we would have had it back then because it took a long time. I live in St. Louis. I was very fortunate to have a lot of private care here. And we even had one hospital that did eating disorders diagnosis at the time. Now we have both of our major hospitals, both Children's and Cardinal Glennon, do eating disorders diagnosis and will do inpatient treatment if it's necessary. I know Kansas City Children's Mercy is excellent, has an excellent eating disorders unit. And again, those are sort of the best options in the state right now. But at the time, I could get her diagnosed, but I couldn't really get her treatment anywhere but private care. And this was back in 2008, 2009. So we've come a long way in the last 20 so years. Anyway, it was a devastating illness for our family. It was incredibly hard, a hard and difficult time for us. She was a monster in our house. I'm sure many of you know this, but I feel like families really get the brunt of the illness because, all of the party, like the good manners are gone. And they're just home kind of wrecking havoc because the illness has made them so sick. And we were really fortunate in that she was able to get sufficient care. But during that time, we spent so much time and energy trying to get insurance to cover her treatment. And it became a real point of frustration for me because we would go to parents groups for support on how to deal with the illness. And we would spend the entire time talking about how insurance was denying treatment, that their kids were going to be kicked out of treatment the next day. What do we do? And that was constant. So in addition to the council, legislation around the council, we also got to work on an insurance mandate that requires insurance cover eating disorders fully in the state. And it is my understanding from some healthcare providers is it's really changed things. Now insurance can no longer kick people out of treatment just because they say so. they have to listen to the treatment team and the recommendations of the treatment team. It is now a law. And this law in particular is meant for self-insured people, because it's really impossible. I mean, first of all, it took 8 years to get this law passed. This was not an easy a bill to get passed in Missouri, because the insurance lobbyists are so powerful in the state. But we were able to get it passed. It covers self-insured policies, which is different. So that means if you're with a corporate policy, you're not automatically covered. But what I found is, if you take this law to the company, to your HR department in the company, and you say this law exists for self-insured and insurance must cover it for this company as well, they will cover it. That's what I'm hearing, is they do it because they know they have to. So they're not legally required, but ethically they're required. So the bill number is SB 645, and the bill sponsor at the time was David Pierce, Senator David Pierce, and Representative Rick Stream. And it is one of the best mental health parity bills in the country, and it is very specific to eating disorders. So I can't stress enough to pull that resource. If anybody wants more information on the bill, I'm happy to provide a written document on how to use it, what it is, and I'm happy to provide the bill too, so that you can give it to the people that you know who are affected. But anyway, that's kind of my story. You know, it started in 2008, and I guess it was around 2015 that we passed the last and the biggest bill, which was the insurance mandate. So ever since then, I've been chairing this Missouri Eating Disorders Council, which is a profound pleasure and honor. I work with the best eating disorders professionals in the state, I think. And if you're also a great eating disorder professional and would love to be a part of our council, please reach out. We're always looking for more people to come and represent, bring their voice and their expertise to the council. And we love geographical diversity too. So come on in if you'd like.
I was going to also say, Annie, thank you so much. Sort of the best part of this is your daughter is recovered.
Yeah, I mean, I think that I didn't even say that. You know, it's so normal for me now to have her recovered that I don't even think about it. But my daughter's 30 now, and she is in her last year of graduate school, and she is super high functioning and awesome, and she's going to be out there and make a huge difference in the world. You know, I used to always say, you know, eating disorders affects our best and our brightest. There's definitely personality characteristics that sort of makes you a little more predisposed to this illness, even though it is a very biologically based illness. There are still personality and characteristics that feed it. And those are the characteristics that can also make people extremely successful. So it's, you know, it's a horrible illness, but it's highly treatable. And early intervention and aggressive treatment are really the keys to better outcomes. So I hope you guys can see that everything's sort of working together in the state here, where training people on how to diagnose and treat, providing this online program are really, really important to drive that sort of earlier intervention, better outcome model that we are starting to see here. So does anybody have any questions for me? If you do, we can ask them later too, or put them in the chat.
And I think we were going to hear a little bit from Marie-Laure. She's very gracious and being willing to share about her story. Thank you so much, Annie. Amazing work.
Yeah, thank you so much for having me. And I think it's always very humbling as someone who was the monster in the house to hear from a parent's perspective. I've had many conversations with my mother about their experience, and I'm always so grateful for them to have done everything they could. And I also always understood like how they tried their best as parents. And I think that's important to remember, like they don't know how to deal with us, and they're really, really trying their hardest, and they just want to save us and take the pain away. And so, Annie, thank you so much for sharing your story. So I was I struggled with eating disorder. I was diagnosed at the age of 16 with anorexia nervosa. And my story is a little bit different because I actually grew up in France and was diagnosed in France. But I received treatment in France, and it's really when I received treatment that I knew at the age of 16 that there was something wrong with the way they were treating people with eating disorders. I did not like it. They made comments that I was like, this sounds. In insight today, I'm like, you should never say this to a patient. But they made comments about my BMI being too high to go to inpatient. And just without checking numbers, my BMI was below what it needs to be diagnosed with an eating disorder, but with anorexia nervosa. So, and as a person with anorexia nervosa at the time, with what I registered was like, I'm too fat to get treatment. And they put me in outpatient, but that damage, I think, was kind of done. And I'm somebody also who, like, if I'm going to, when something happens to me, I need to research it. I need to learn it. I need to know about it. So I would go to the library and read books about eating disorders. And something that always annoyed me was like, well, this is a fairly new disease. It's young kids these days, they have eating disorders. Back in my day, we didn't have that. And so I would go and like research it, be like, no, this is not new. This is like, it's always been there in different ways. So I started like really learning about the disease, and the more I learned, the more I decided to go into social work, and it's like wanting to learn about different treatment, evidence-based treatment. I was like, what I got for therapy, like just to give you an example of someone anorexia nervosa, we know, at least in the therapy that we do, family-based treatment, which is the evidence-based, like you would weigh the patient weekly, or at least weekly, to know like how they're doing. They never weigh me. I would go in and I would say random weights, and they would just take my word for it. And of course, I would not say the truth. And it's very damaging because I got extremely sick. But never really made sense of my own recovery for years. Didn't really understand how I recovered. And my parents did something that we would never probably recommend to anyone to do that would come to our program, but actually went to the United States. They were like, if you're not gonna get better at home, and I don't remember ever saying this to my mother, but it really reached something that is still to this day very hard for us. I said, if I don't go, this was my dream, going to America since I was a little child, and she said, if I don't go, I'm just gonna let myself die, because that's the reality of anorexia nervosa. I mean, there's no perfect weight. You're just waiting. It's a slow suicide, and that's what makes these diseases so dangerous. And so they let me go. And I got better, not magically better. Took me years and years to finally have good relationship with my body and my eating, but I did got at a better, healthier weight, which then the depression and everything that goes with it improves. And a couple of years ago, during one of our training, I met Dr. Locke, who helped manualize a family-based treatment. And during his training, he said, with anorexia, the person starts healing when the life becomes more important than the disorder. And when he said that to me, I was like, that's my recovery journey. I never made sense of it because I went to therapy, was doing things on my own, but I never really, because I never went to traditional treatment, I guess in my head, I was like, oh, I can't recover. But this sentence he said, and then I got to meet with him and talk with him about this. And it was very, very, I think he made, I was like, whoa, you made sense of how I recovered. And he was like, really, life became more interesting than the eating disorder. And I'm not like, it wasn't magical. It took me, as I said, through college. I know I had disordered eating. And then it's like through therapy and other skills that I learned. And really I don't like thinking things happen for a reason. We don't think, but I do think we make of our struggles, we learn to make something of it. And it became my passion to work with eating disorders, and I wasn't sure in what way. I thought I was going to be a therapist, so got my master in social work. But about 7 years ago, the position of Body U coordinator opened, and I think that was like the perfect fit for me. As I said, like this through this program, I got to watch it grow from like 4 universities to 12 universities, and really create programs on school campuses across Missouri to really talk about eating disorder, promote awareness, try to bust all these myths that we have, and try to help students learn about healthy body image, healthy eating behaviors. We've done many presentations, and I've talked to many students about these topics of things like how do you talk to a friend who have an eating disorder, and it's always been kind of things I wish my friends would have done, because we had really no education on anything eating disorder related. Comments that you can receive are very hurtful when people don't understand the disorder. You definitely lose friendships. That's something I was thinking about this presentation, like the loneliness and how you even closest friends, you're not pleasant to be around, and you're not pleasant to be around because you're suffering, and because it's not something you want to do to people. Like, it's just the disease and the suffering. So I got to work on this Body U and really like work on helping creating the programs, and really thinking as we talk about them as a team, which is always wonderful to have like the academia side and the research side, but also kind of always thinking about what did you feel like for me, what was helpful, and making it, sometimes trying to make it more personable too, with some stories throughout our programs. And I mean, some of them without coming directly from my experience, but I was like, how was I, trying to go back to like, how was I feeling? And I will say, you have to feel strong in your recovery to be able to take a step back to where you were feeling at your worst. And I'm very lucky, and I've worked really hard, I should say both, to get to this strong recovery. But things in our programs that we talk about are like coping skills, coping with trigger warnings, that I think to me are essential. There's a lot of anxiety with eating disorder. There's a lot of anxiety often with like these triggers, whatever they might be, and turning to eating or not eating, or also we use a lot of body image and think about, oh, because I saw somebody on TikTok or Instagram with a perfect body, but there's also all these other triggers that goes differently into your body. It's like, I got disappointing news. If I would get a bad grade, I would go, well, if I were thinner, like that would be my go-to. Like if I were thinner, I'd have better grades, which makes no sense whatsoever. You don't get better grades by not eating, and actually makes it worse because your brain needs that fuel. But it's just these little things that often we don't think about eating disorders. Is like we think more of the body, the weight, without thinking, or like the images on TV, and don't get me wrong, like these images can be very detrimental to people, but all this comparison against perfect bodies, or what is seen as a perfect body by our society. But there's also everything else, like the breakup, or your friend that did not invite you to a party, or as I said, like whatever it might be, disappointing news, or can really trigger some of these symptoms and behaviors. So these are like things that we work on with our participants. And yeah, that's a nutshell of my story. And just one thing I would say about Body U that we have not mentioned at all. If you want to access Body U, you need to go to bodyu.org. And it's free and available to all Missourians. So it can be if you know somebody in Missouri who you think may be at risk of an eating disorder, you can share this program with you. And again, it's bodyu.org. And if it's okay, I'll put it in the chat.
Absolutely. Thank you. I want to thank you all for participating today. And I'm going to ask just a few questions to the panel. And if anyone that is participating would like to ask a question or put a question in the chat, if you don't feel comfortable asking the question. And I think our participants probably have a variety of backgrounds. So some of my questions are going to be varied in the nature of the background or the questions. Dr. Wilfley, you talked a little bit about what medical professionals can do to help, but for non-medical professionals, how can we identify symptoms or signs and spot the warning signs of eating disorders? And what can we do to help those that may be suffering to identify an eating disorder and seek treatment? And that this is open for all of you, but I'll start with Dr. Wilfley.
Yeah, I think that's a really good question. And like Annie said, as a parent, even though she wondered, she just didn't know at that time. And so I think if those signs and symptoms, a nurse could go to the parent directly and talk with them if it's a teenager, or a teacher, like Annie said. But I think the most thing that, like Annie said, is that the teacher reached out and said, I'm concerned about your daughter. I noticed that, her grades aren't going as well. And, she's usually more interactive and she started to isolate, and I'm concerned about her. So I think and then to the individual, I think pointing out, not saying, oh, your weight, either like you've gained weight because, maybe the person is binge eating, maybe they have gained weight, maybe they've lost a lot of weight. And so not communicating on weight, but to talk about that, you just want to check in with them and see how they're doing, and that there is support. The National Eating Disorder Association, does have screening individuals that can talk with parents. Our Body U resource, even as a parent, we had a mom last week, Annie and I were able to present, and she's like, I want to get on Body U, and I'll work through this, and so I think that's another thing, because it does teach some of the fundamental skills that are helpful with people overcoming eating disorders. But I think mainly pay attention to your intuition about, reaching out and showing a lot of compassion and support. And Annie, you may want to add, or Marie-Laure.
Yeah, I've got some things I can add. Yeah, that was great, Denise. Thank you. And Marie-Laure, thanks for sharing that about. I've never heard your personal story, so that was great to hear. Nice job. Yeah, so I think there's some things that you can look at. So I mentioned it's confusing. It is, but if you see these things, I would be concerned. One is not eating, making excuses about food, simply not participating in meals, taking themselves away for whatever reason. And people are busy these days, but after a couple of weeks of not eating a meal with your kid, with your loved one, you start to wonder what's going on. Especially if you're having family meals. I would say the other thing is rituals around food. If food is starting to become good or bad, that's a very alarming thing. It is pretty common for people with eating disorders to classify things like butter and cheese as really bad foods. And it is very almost impossible for them to eat it when they're in the throes of this illness. So when you start hearing things about never eat cheese, never eat butter, never eat pizza, these are bad things. Also, obsession with labels, reading nutritional facts panels as a child. I tell the story about how I was kind of proud of my daughter for reading labels until I realized that she had to read every label before she could eat anything. And that is not healthy. I would say a change in behavior, a marked change in behavior, when suddenly someone becomes isolated, withdrawn, moody when they weren't before, I would say is a cause for alarm. The other thing is simply losing weight. And Denise mentioned, you don't want to engage on the losing weight, but generally speaking, as a rule, adolescents should not be losing weight. So I've talked to a number of parents who said, it wasn't until they were like prom dress shopping and they saw their daughter trying on prom dresses that they knew there was a real problem. That is a real thing for parents with eating disorders, because kids will hide out. Like, you're not going to see their bodies because they can't even look at their bodies. Another thing is extreme dysmorphia or hatred of their bodies. Constantly talking about the fact that they're fat when they're not fat, constantly picking themselves apart, hypercritical behavior. Those are all real indications that something's going on. And these are not subtle. None of these things I'm like telling you to look for are subtle. These things are loud and in your face, like extreme. My daughter used to throw herself on the floor screaming she was fat, she was fat, she was fat. Like, throw herself on the floor because she was so ill at the time. And she just could not, there was no arguing with her. And then the other thing is, if there's a binge eating, sorry for my dog, if there was a binge eating happening, excusing themselves to go to the bathroom after every meal is a real red flag. So watch for that. There's also exercise bulimia, which is another thing you can watch for, which is over exercise and inability to stop exercising. So it's sort of like the kid who runs cross country, who's done with the workout and says to the coach, I'm going to put in one more mile. I'm going to put in one more mile. I'm going to do it. I can do it. And they cannot, they can't choose. They can't stop. So, my daughter ran stairs all night. She did jumping jacks all night. She did sit-ups all night. Those are all behaviors that if they're going on and you see them, you should, I would say, be cause for alarm. And then the really big one is if your child or adolescent starts fainting, I would take them immediately to the emergency room, because they're not supposed to faint. So something serious could be going on. Because again, a lot of the actual compensatory behaviors of an eating disorder are very secretive. Like the purging, you won't know they're purging. All right, I'm going to get off because my dogs are barking. But Marie-Laure, anything to add?
Yes, definitely. All good suggestions, Annie. Like, one thing I would add is, like, don't get locked into the diagnosis and the idea that we have with eating disorder. Like, someone with anorexia nervosa can purge, and they can do that after every meal. They can do that throughout the meal. They might give the impression of eating and then getting up and going to the bathroom. I was going to say about the exercise, if you're like me, live in an old house, you can hear from room to room. Like, sometimes if there's a lot of jumping around, because I've done these jumping jacks at night with the sit-ups and everything, because you just have to burn the calories. If the scale in your house moved room from your own bathroom to their bathroom or their bedroom, that could definitely be a sign of something, that they're weighing themselves several times, once a day or several times a day. Any changes in behavior, I mean, I think that's the biggest one. Like, your children best. And even as professional in school settings, like, you get to learn to know these children, and any change in behaviors, like someone who always loved eating and then suddenly food is, they just stop, or they want to eat less. What Annie, you said about the prom dress shopping was definitely, even though not prom, because we don't have that in France, but definitely shopping for clothes was a big clue for my mother that something was wrong. That was like her big red flag. And then she started looking at how I was eating. Like, you open her eyes to wait, my daughter's not eating as much as she used to. I always loved food. So it was like if you had asked me before I had an eating disorder, if anorexia, like I would be like, oh, probably bulimia nervosa or some binge, like to go from like loving food so much to food being the enemy. And I had one more back here. Oh yeah, depending on your age, but also I know this can start pretty young, but alcohol consumption, if they start drinking more and getting drunk more often, this can also be a sign of not just doesn't have to be an addiction, can really be a sign of an eating disorder.
Mm-hmm. I have two more too, Marie-Laure. Thank you. Those were good. One is vague ailments. So stomach aches, headaches, maybe they think they're, like just vague, kind of weird, but chronic, like every day there's something. Because don't forget, they don't feel good because they're not eating. So, or they're purging. So vague ailments. Like we spent a lot of time in the doctor's office before we had her diagnosed with an eating disorder, with one strange ailment after another. And then the other thing is, it is common for people who are in the midst of an eating disorder to feel very cold. Because again, all of their energy is really going towards the functioning of their body. So keeping their temperature regulated, it can be very difficult. So, if in the middle of July, you have a kid who's wearing sweatshirts, sweatpants, socks, a hat, and they're freezing all the time, I would also say something's probably going on too. First of all, they're hiding their body. And secondly, they might legitimately not even have the energy to keep themselves warm. So those were two other big ones that we saw.
Right. So Dr. Jones, our Director of Public Health, had to leave, but she wanted to ask this question. And it was one that I had, and I'm very curious about this, especially with the work that you all are doing at Washington University. And she asked, how can, from a public health standpoint, and I think it's really more of a general standpoint as well, can you talk about maintaining healthy weights, BMI, without triggering eating disorders? And we talked about this a little bit beforehand. Between go ahead.
Yeah,
go ahead,
it's a very, very important issue, and there is an explosion of obesity in our country, and what that has led to is, by 2060 there'll be a 700% increase in type 2 diabetes. And I've worked with kids who are very ill, who have microvascular complications as a result. So it is important to be able to sort of balance. But I think the big problem we have in our country that is one, there's a big business in the diet industry. So people are given misinformation about eating, skipping meals, not eating certain types of foods. That's very problematic. So one of the things that when we work with families, and if a child does not have an eating disorder, you always want to screen and monitor. But really, it's about getting the whole family involved. Everybody's weight and shape, it's variable. There's no set specific number for anyone. And really, it's about using weight as, one index, of all the other things that people can do to have, take care of yourself the best you can, just like we would talk with individuals who are recovering from eating disorders, making sure you're getting sleep, making sure we really want 3 meals and 2 snacks, because we know regular eating limits the likelihood that you overeat. And also the other big problem we have in our country is access to healthful foods. We have, the food industry has pushed very unhealthful foods to kids, and we don't want someone paranoid. And, if I eat something that isn't, plant-based or, the most healthy food, that they're bad, because foods aren't bad. what is problematic is that if kids aren't getting, a good range of nutrition. And I think the problem for a lot of kids at school, if they do have a higher BMI, what's most damaging is negative verbal commentary, teasing, bullying. We've had, individuals who struggle with severe obesity, and they talked about teachers being very mean to them, nurses, healthcare professionals. And we know that stigma makes every problem worse. And so I think it's really important to be compassionate. There's a lot of reasons people have different weight. So it's really a delicate balance. And I think from a public health standpoint, the more that we can really work in communities to provide better access to healthful foods, make it easy for families to have these, make it easier for families to be able to have this fit into their budget, make it easier for, people to feel safe in their neighborhoods where they can get out and walk and have community. I think those are the sort of big public health messages. And also enjoying your body, no matter how small or how large it is, because there's a lot of great things your body does. And I think having that message is really important too.
One other question we had, and I know my daughter answered this on the chat, but what does treatment look like? And I think it looks a little bit different maybe for each individual case, but what different types of treatment are there for eating disorders?
Well, the first thing is that if someone is, medically compromised and they need to be put in to have weight stabilization, have their medical values stabilized, like that's first and foremost. And so then hopefully, ideally, we might catch people before that, right? And in that situation, for teenagers and children is we've done work at WashU, but it's really been family-based treatment, getting the caregiver involved in refeeding the child and doing it in a compassionate way, but also a way that communicates that they're there right by their side and you're going to do this together. And we do have, again, training available on that. And Dr. Locke out of Stanford, he's been so amazing, like really making sure people have access to this treatment and the knowledge. So I think, and then other treatments, interpersonal psychotherapy. Many people who have eating disorders have a lot of social self-consciousness, a lot of anxiety, a lot of worries about how they come across. And so then it becomes redirected towards their weight and shape. And, we teach people that, having one social tie, one positive, improving ties with parents, improving ties with people in their environment, can be very important. And then the other treatment that has been shown to be very successful is cognitive behavioral treatment. And a key part of cognitive behavioral treatment is really stabilizing eating patterns, getting people to eat 3 meals a day. And you'll see the one other sign that you will see with eating disorders, oh, I'm just not hungry in the morning. I would get sick. I can't eat. And so, we really work with getting individuals who struggle with eating disorders to experiment, try increasing these meals. They're scared about weight gain. And what they find is that their weight actually stabilizes and they're not gaining weight by increasing these meals. So that's another key feature, as well as identifying what are those triggers to binge eating. Is it, if you're putting in long work days and you're not taking breaks for yourself, then that's a trigger, allowing yourself to not be perfect, working around good is okay. So those are kind of the key treatments. And then there's also another treatment when there's really extreme emotional dysregulation. Dialectical behavioral therapy is another treatment. So we do have effective treatments. We just haven't done as much to get those treatments out there. And then in some cases, pharmacotherapy is warranted as well. Although pharmacotherapy for eating disorders has not been as prominent as really the psychological treatments.
Yeah. And Andrea, I can cover, if you want me to cover the structures around, like, the different types of, so Denise just did a great job of explaining the evidence-based treatments, which is awesome. There's also so many different ways you can get these treatments. You can either do therapy sessions with an individual therapist, preferably finding someone who's trained in evidence-based practices. We really like, as a council, we really like this integrated care team model because eating disorders can move up and down in severity, requiring different types of interventions. But we definitely believe there's a role for a dietitian on a treatment team. There's a role for the primary therapist. There could be a role for a medical professional, either a doctor or a nurse practitioner or a nurse trained in eating disorders. There are other therapies too that can be very enhancing when it's part of the broader treatment team. Because sometimes when someone has a severe eating disorder, it's hard just to reach them. So all of those things kind of work together. But if you're going to a place for treatment, there's typically what is called inpatient or residential treatment, which is a treatment facility where you stay 24 hours a day and you will stay for a period of time, anywhere from 1 week to, I don't know, months, depending on the severity of your eating disorder. And that way you get round the clock supervision, you have your meals prepared for you, and you're really, really focused on getting yourself stabilized and then grabbing the treatments, surrounded by the treatments, so that you can work to get yourself well. Then there is what's called inpatient, which can be anywhere from typically 6 hours a day to 10 hours a day, again, depending on the severity of your eating disorder. And in those programs, you typically eat your meals there. And again, you have a full day of therapies. You may have group therapy, you may have your individual therapy, you may have your doctor's appointment, you may have school studies like tutorial time. And you might actually have some family time as well, because FBT is proving to be family behavioral therapy is proving to be so effective in treating all of these eating disorders. And then the last sort of version associated with an eating disorders treatment center is what's called intensive outpatient, which is usually around 3 hours a day. It can be anywhere from 7 days a week to 3 days a week, just depending on the program. And the IOP program, intensive outpatient, is designed to mainstream you back into the world so that you can take all of the good practices and all of the good therapies and have practical applications. So you might do things like go to the grocery store, go to a restaurant with your IOP group, and then you come back as a group and you really process how those experiences were for you. So you can see that there's a variety, right? It goes from very intense. Oh, and then inpatient is typically hospitalization, which Denise referred to earlier, which is, if you're in acute in a very dangerous place, you need to be there to get yourself stabilized, get your liquids get your liquids in your body, maybe a feeding tube, whatever it takes to get you medically stabilized, so that then you can begin the work of treatment. So treatment can look lots of different ways because this illness can look lots of different ways. And the people who have this illness can look lots of different ways. This is just a very, very complicated and serious illness. And so having all of these different types of treatment is typically the best, we found.
I did want to just add on to a comment that Annie made in terms of obesity as well. Similar to eating disorders, it's important to treat it seriously. And I think part of the issue has been, and the confusion is that the dieting industry has sold it as just, try this fad diet. And I think similar to what Annie said, integrated treatment with having a pediatrician or physician support, and also these family-based lifestyle treatments can be very helpful, because it's oftentimes with support, because these kids are at really high risk for developing eating disorders. So doing it in a way that really supports them is super important. And that's why the American Academy of Pediatrics, recently released guidelines around making sure that children have access to these healthy lifestyle, family-based programs.
So one of the questions was related to suicidal ideation. Is the deaths associated with eating disorders, is that from the physical manifestation of eating disorders, or is that associated with suicidal ideation?
It's both.
Yeah, go ahead.
Oh, sorry. No, it's both. I mean, people with eating disorders, the last statistic I saw are 48% more likely to have suicidal ideation and follow through. Don't forget, I mean, when you look at the personality characteristics, what it takes to follow through on an eating disorder, the rigor and the rigidness, when somebody starts to suicidally ideate with an eating disorder, you need to take it very seriously. But those co-occurring medical conditions are really the things that make this illness the most fatal. That makes anorexia so terribly fatal. So it is common for people with eating disorders to have heart conditions, kidney problems, osteoporosis, teeth problems. They can have brain injury, and many of these co-occurring medical conditions are permanent and like a lifetime of real despair and difficulty. So, again, intervening early is so important to make sure you don't get the chronicity of those medical conditions.
And I think it goes back to what was said earlier about early detection, early intervention. And can you just talk a little bit about how important that is, and not only the length of the treatment and recovery, as well as kind of addressing some of those lingering medical conditions?
Yeah, I think that is why our work pivoted, because we were seeing so many adults. And when we did risk factor research and we looked at when the onset of the disorder was, it was clear so many were in childhood, teenage years. And that's why we pivoted and started working, in colleges and with teenagers. And not that I do think that there are people who have eating disorders that have an onset in later life. Justin mentioned in the chat that it was dealing with hardship. A mom lost her son, and the eating disorder started after that in her 40s. So any big stressor like that, for some individuals, a coping strategy can be the eating disorder. And I think sometimes people who struggle with eating disorders get so caught up in the eating disorder, they can't see that. So that's why it's so helpful to really work with someone and kind of retrace your steps. Like, well, what was going on in your life when the eating disorder started? We've had people where, their parents divorced. There can be another situation, being bullied or teased, or a coach just happens to tell someone that they need to lose weight when they don't realize this person is already wound so tight and doing everything they can that it pushes them over the edge. So I think, it is really important to have those resources. And also for people who are in high leadership positions with young people. I know one of the things, my daughters turned 16 soon, and one of the things that has changed is safe sport practices, and a lot of education of coaches about this, which has been absolutely phenomenal. And what about educating all the coaches, all the teachers, and then, making sure that they know that making weight-based comments is very shameful and very problematic. And it actually doesn't even get them where they want. It backfires. It's very debilitating for their athlete if they think it's going to fuel. So I think those are the types of things to do. And I do think public health messages are really important, and how do we frame this, and definitely not stigmatizing people based on their shape or weight is super important.
I've been trying to watch the comments, but if there's anyone on here that has a question that I think we have raise your hand, the function on here, or wants to unmute and just ask a question. If I've missed something, please jump in. I think we have a small enough group that we can manage it that way. But I want to make sure that everyone has their questions answered. You know, you talked about athletes, and I've heard about very high performing athletes, even if it's not the coach that is pressuring them, that they can often suffer from eating disorders because of the pressures that they put upon themselves. Marathon runners, triathletes, you know, how do their eating disorders differ, if they do, or is it the same type of eating disorders, and how do they suffer like others?
Yeah, I think we see that a lot. And I think it's the confusion that thinness leads to performance, when in reality, feeding the brain and feeding the body with, appropriate levels of fuel is super important. So I think that is really the message. And I think coaches, even if they're not giving messages, they should watch for signs, but also talk about, what do athletes need if they're working out for 2 hours a day, swimming or running? What kind of nutrition do they need to actually appropriately fuel themselves? It's very important.
And there's a whole field of study around. Oh, I'm sorry, Marie-Laure. Go ahead. Sorry, didn't mean to cut you
I
off.
was just going to say, I would add that this can happen with like people who do sports that are not in the Olympics or big star of their sport. Like, I'm a very, very mediocre athlete. I had to learn to do it for enjoyment and not performance. And yet when I was in competition, I did gymnastics and competition, I would put all that pressure. That did not matter because I was never going to make it to a national team or whatever. But yet my personality was, I have to be the best out there, when there was no chance I would be. But I put way too much hours and effort, and because there's this part of your brain. So it's not just the big athlete to watch out for, but also anyone who does sport and then go into the perfection mode.
And oftentimes, there are studies that show even sometimes athletes that aren't even at the top level, but like you're saying, have more eating disorders. So I think not making that assumption. There's another message in the chat. Michelle, you brought up, you said, have you found bulimia leads to copycat bulimia? And you say, I recall girls in my high school starting to binge and purge after discovering other girls were doing it. They considered it a tool for weight management, very troubling. Bulimia became sort of a social group. And that's absolutely that kind of social contagion. And there are individuals that are able to move out of those behaviors. They try them and they don't stick. But there are individuals, and it might be that there's problems on the home front or other issues, or, we have a lot of individuals who we find that they have attentional problems or really struggling at school. And so if eating disorders become a way they can numb out and not have to deal with those pressures. So I think it's very problematic. And I think that's why, teaching kids how they can help recognize these issues.
Yeah. And can I just build on that for a second, Denise? Because I think it's important too that people understand that this illness is very biologically based. So like Denise just said, not everybody who follows binge, purging at school is going to develop an eating disorder. There are actual genetic markers that make you predisposed for this illness. And then a trigger will happen to put you into the behaviors to exacerbate the illness. And the more we can think about this illness as sort of being biologically based, the more we can destigmatize it. Because, you know, what you're able to do then is you're able to interact with this illness like you would the flu and cancer and any other illness that's debilitating. And I think that's really important. It is definitely a mental illness, but there are really strong biological, I think it's about 85% of all people with an eating disorder actually have the genetic markers to have it. About 15% of them will come into an eating disorder because of trauma or some other, you know, mostly trauma, but some other horrific event that puts them into it. So it's just important to have perspective about this, I think, because there's a lot on here around triggers and things like that. And triggers are terrible, but triggers don't trigger people who aren't predisposed to having this illness. Like one comment, you know, otherwise, I mean, I like to say, you know, otherwise everybody in this country would have an eating disorder because we're all exposed to ridiculous images of beauty, unobtainable images of thinness and achievement. I mean, it would just be, we would just all be very, very ill. Now, we all have a lot of disordered eating, but we don't all have eating disorders. So just wanted to put that in.
Hey, this is Ursula. I'm on a regional board for suicide prevention, and we do educational pieces like this for therapists. And I was just wondering if you would take this show on the road and work with us on sharing this insight. I always thought there was only one kind of fatal mental health disorder, which was depression.
Mm-hmm.
And I did not know that's why I was asking about, did you have those thoughts as well? So I would love to have you guys as a group be on a panel with us, and we train usually we have about attendance of 80 to 100 folks.
Sure. We could probably brush some things up, but we could do it.
I love it just the way it is, just the way it is.
You know, Ursula, we talked about the co-occurring physical conditions, but there are comorbid conditions too, which are anxiety, depression, super, super hand in hand with eating disorders.
Okay.
Oftentimes people will go in for depression, but really have an underlying eating disorder. And the eating disorder has to be treated in order to treat the depression. So there are a lot of mental, you know, comorbid conditions that are really, really deeply tied to eating disorders. And we would be happy to talk about the suicidal aspect of this illness specifically, because it's really terrible.
Okay.
Hi. Yeah.
Well, I will get with Delana to see how I can stay in touch with you guys.
Yeah, thank you for doing such important work. And I do think because they are so vulnerable, and back in the 40s, there was a study done of World War II conscientious objectors, and these were men at that time, and they starved themselves, and they studied what the impact of starvation was, and they got very depressed and despondent and obsessed with eating. So many of these symptoms can arise just out and out by starvation. And then, of course, there are other issues like attentional problems that can make people much more vulnerable to binge eating, overeating, and then depression as well, and feeling like there's no hope. And then on top of it, if somebody has those problems and they're told the solution is just to lose weight, you can imagine how incredibly devastating that would be.
Exactly. So some of what you guys said resonated with my children. They didn't develop eating disorders, but I happened to be a thin person who had full-bodied children, and they went through some of the things you talk about. Wrestling, coach was trying to make my kid lose weight and shed weight and all of that stuff, and I said, well, he'll wrestle where he is, and he was just getting too big as a high schooler to do anything. But yeah, and so you don't know what you're dealing with, and so kind of how you all shared, you know, the depths of, you know, what triggered it and where it came from and what kept it going. I think is very important for a lot of us to know.
And Ursula, I want to commend you for fighting with that wrestling coach.
Yeah.
That is really honestly one of the sports where you see the most, like the highest incidence of eating disorders in boys, believe it or not, is in wrestling and in long distance running. So good for you for fighting with him on that.
And I mentioned earlier, Ursula, I love what you do and love to participate. So thank you so much. I mentioned, like, to me, anorexia felt like slow suicide, because there was no getting better, because there was like, I kept having perfect weights in mind. You know, it's like, if I get to this weight, then everything will be okay. If I get to this, and never got close to that weight, that I would change my goal, right? So, and the perfect weight for me, if it had been possible, would have been negative pounds, you know. And it was like really until I died, it was gonna continue. Like, there was no perfect weight, and I think it's like the disease taking over your brain, and as Denise mentioned, like the depression from starvation, that's very, very real. And it's something I very definitely experienced. And you're just so miserable. Like, I think it's very important to remember the person doesn't do it. It's not a cry for help. It's not, and I'm sure they kind of like commonality with suicide, right? It's not a cry for help. It's not, I want to be part of the cool girls club, or there is a lot of suffering. And I think anyone who works with people with eating disorder, like, empathy is so important, and remembering, like, we're talking to real people that really want to get, a part of them want to get better, because they are miserable, and nobody likes to be in so much pain. And I think that's kind of like the issue with, like, suicide too. When you're in so much pain, sometimes you just want that pain to stop.
Yeah.
Yes.
Yeah. Thank you, Marie-Laure. I think Justin had his hand up. And I just wanted to say before Justin speaks that the fastest growing population of people suffering from eating disorders is our males, and then women over 40. So anyway, I think Justin had his hand up. I don't know if he still does, but.
Well, I'll just, I saw this on Councilwoman Bough's social media, and I think it's fair to say that I am running for city council in Kansas City, so I don't want people to think that I'm on this call for some sort of performative reason. You know, my experience, it's not easy to talk about, because my experience is not a success story. It's something that I'm still living with, and I relapsed in 2020 in a way that was deeply, deeply hurtful, and I got really sick. And I remember in college, it looks like we got 5 minutes left. I'll be quick. In college, there was a comment that was made, and it triggered this darkness, and we ended up calling it Ed. It had a name at some point, because I was able to disassociate myself from Ed and what Ed would do to me personally. But the complete lack of control, the complete lack of understanding what you're doing to your own body. And to Marie's point about not being able to see your goal as an attainable goal, but keeping moving the line, was always something that was happening. I mean, I got to the point where I was 1 apple a day and a Dasani water bottle. That was it. That's what I was doing for months. And I was a cheerleader at the University of Missouri. I was practicing every morning. We had basketball games. We had football games. I was running off of that. And there's, you know, that doesn't go away. But the thing that is important for people to know and people to understand is that it affects a swath of folks. And for me, it was the complete lack of control of things that were happening around me. I was coming into my sexuality. I was coming into who I was as a person, and none of that was in my control. But what was in my control was what I was putting into my body. And that's how I exerted control over myself, to be able to start to have control over my life. sounds like this meeting is going to end real quick, so I don't want to.
Well, what I do want to say to you, Justin, I really applaud you for bringing it up. I think that oftentimes because not as many men have, so it's more stigmatized. And I think it's also very common when individuals are either, moving through gender or sexual orientation, concerns, worries, transitions. It's not uncommon that, the coping gets borne out, with the body. So I think I really appreciate you bringing it up.
I am not one who is super ready to talk about it all the time, but I will do it for Councilwoman Bough in a heartbeat.
Well, and I just want to, I've known Justin for quite a while, and he was open enough with me to talk about it about a year ago, probably. But what I want to tell him and tell others that experience this is that recovery is something that occurs for a long period of time, and you have to be good to yourself and know that it's okay if there is a relapse, and recovery is a continual process. It is, I had back surgery in November, and so I got out of the hospital and I wanted to be instantly okay and have no pain. It is not it's not even a linear process. It's something that you have to say, okay, this may be something that I live with the rest of my life, but you have to be good to yourself and know that with the help of people who love you, that you're going to get through this. And so I just want to end this on, a good note that say, Justin, we love you, and we love all of those who are in recovery, who've experienced this illness, and that the purpose of this, this discussion is to say, the more we talk about this, the more we acknowledge this, the more that we can come together and say that this is something. And I love what you said, Annie, that this is more biological. This is something that we can acknowledge, like, the fact that my disc degenerated, and there's a solution to this problem, and we can join together, we can address this, and and we can stand with each other, and we can get help. And that's why we're all here today. So we're at 7:29. So I just want to thank the panel. This has been wonderful. This is our first time trying this. I didn't know what it was going to be like, but I think it's been wonderful. And I just want to thank you all. I hope we can continue this on an annual basis. 8 years ago, we, well, I guess this is our 9th year now. We, my daughter and I asked the city council to start recognizing Eating Disorder Awareness Week. It's probably the first time that, it was the first time the city even talked about eating disorders. And we're starting to grow, I think, the health department for bringing this issue to the forefront. I thank you all for participating. And, if you all have any closing words, I want to let the experts wrap us up. Hopefully you'll see our buildings in downtown Kansas City, blue and green. Well, actually, I think tonight and tomorrow they should be. I may have to run downtown. Wait, Justin, can you go outside and see if the buildings are blue and green and take a picture for me? But I just want to thank you all. I don't know if you have a few quick words to close this out. Maybe Dr. Wilfley.
Well, I just want to very much thank Marie-Laure. I know this is her first opportunity to share with the public about her recovery. So I'm really grateful for you to be willing to do that, Marie-Laure, and also Annie, to give such inspiration to parents. I think is super important. And also, just really appreciate the focus on eating disorders. It makes them important. I think hopefully there'll be more attention and more people are going to recover because of your willingness to do this tonight. So really appreciate it.
All right. Thank you all, and have a good evening. And thank you all for who joined us tonight. Hopefully you can join us next year, and we will continue this. Thank you, Marie-Laure. Thank you, Annie. Thank you, Dr. Wilfley.
Thank
And
you all.
remember, Missouri Eating Disorder Council, we have lots of things for you in the interim. You don't even have to wait a year to get in touch with
Absolutely.
us.
Absolutely. All right.
Bye
Thank you
bye.
very much.
Thank
Bye,
you.
everybody. Thank you.
Bye.